The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.
Welcome to Spot the Bleed, an American Heart Association ICH Guideline Refresher Series, the podcast dedicated to providing comprehensive insights in hemorrhagic stroke care. I'm your host, Sue Abel, Program Consultant at the American Heart Association. We're excited to bring you content that addresses guideline-directed care across the continuum, from patient diagnosis, treatment, and all the way through secondary prevention. In each episode, you will hear from our clinical experts as they break down the ICH guidelines into tangible offerings. Thank you for joining us today as we aim to equip you with refreshed knowledge to enhance ICH care and drive positive outcomes. Let's get started.
Hello, everyone. My name is Dr. Sepideh Chagharvand. I'm a vascular neurology faculty at the University of Wisconsin-Madison.
And I'm Cassie Nankee. I am also vascular neurology faculty at the University of Wisconsin-Madison. So today, Dr. Chagharvand and I will be discussing seizure management in patients with intracranial hemorrhage. We will start with a case, like we did with our previous episode, and we will use this to guide and unfold our discussion. We are going to touch on the importance of detecting seizures as well as treating them as part of the management of ICH, as well as what the guidelines recommend. So let's start with the case. So this is a 44-year-old female, no significant past medical history. She was brought into the emergency room by EMS for seizure-like activity and altered mental status. She received midazolam 5 milligrams en route with EMS, and on arrival to the ED, her blood pressure was elevated at 190/95. She required sternal rub to arouse. And on exam, she was found to have left-sided weakness as well as intermittent abnormal jerking and rhythmic movements. Her head CT showed a right parietal lobe hemorrhage, and her EEG captured multiple seizures, which was consistent with status epilepticus.
So seizures in the setting of a spontaneous ICH occur in roughly 1 out of 10 patients with a range from 3 to 30%. It most occurs with the first 24 hours of hemorrhage. The early seizures are thought to result from structural changes that disrupt the brain integrity, metabolic homeostasis, and transient depolarization. Several studies have looked at the relationship between ICH or intracerebral hemorrhage and seizure. And to summarize, the impact of seizures on functional outcome and mortality in these patients is complex and not fully understood. In general, the risk of anti-seizure medications is low and outweigh the potential benefit in patients who experience seizures following ICH. It's level 1 evidence per American Heart Association in ICH management that treating the seizures in spontaneous ICH would improve functional outcome and prevent brain injury from prolonged recurrent seizures. The treatment algorithm based on the American Epilepsy Society is always benzodiazepine as a first line to abort the seizures. Traditionally, for benzodiazepine refractory status epilepticus, a load of fosphenytoin 20 milligram per kilogram was the second line treatment. However, there are some side effects with that, dropping blood pressure and watching for the drowsiness and more like airway compromise and some titration for the medication dose. So there was this study published in March 2020, which was a clinical trial. It's called ASSET. It was a double-blinded, responsive, adaptive, randomized controlled trial compared efficacy of levetiracetam, which we all know it as Keppra, fosphenytoin, and valproic acid or Depakote for status epilepticus by age group. What they found was in children, adults, and older adults with established status epilepticus responded similarly to all 3 medications with treatment success in about 50% of the patients. The conclusion was that any of these 3 medications can be considered as a potential second-line drug for benzodiazepine refractory status epilepticus.
Yeah, I would say, I don't know about you, Dr. Chagharvand, but I typically use Keppra. That's my go-to there. And thank goodness, because I remember in residency thinking about dosing fosphenytoin and how it's dosed in phenytoin equivalents. It's just a huge headache. So this is actually really helpful on the clinical side of things too. And as I always like to say, Ativan, 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 Keppra, Depakote, Propofol is a good, quick and dirty approach. I'm half kidding. But moving on a little bit. So our patient luckily was hooked up to EEG pretty quickly on arrival, and continuous EEG monitoring is incredibly beneficial for monitoring for seizure activity in these patients. So, and because of that, we know that prompt treatment with anti-seizure medications is essential when we do confirm seizures. Or even like Dr. Chagharvand mentioned, the risk of the anti-seizure medication is usually quite low. So even if you can't get the EEG on right away, if a patient is coming in clearly in clinical status, you're going to be following this algorithm. But it's always helpful to get that data. In patients with impaired or fluctuating level of consciousness. So this can be really tricky, right? Because you're asking yourself, are they just encephalopathic? Are they post-ictal for a prolonged period of time? Or are they having non-convulsive status or subclinical seizures? And it can be really hard to tell the difference without EEG data. So in these patients where their fluctuating level of consciousness is out of proportion to their brain injury or other metabolic derangements, for example, we should always be entertaining the idea or the possibility that a seizure could be going on. And in this case, EEG should be pursued for at least 24 hours. If the EEG looks clean after 24 hours, that's usually, a pretty good indication that it would be okay to discontinue the EEG monitoring. And obviously, if you're seeing status or intermittent seizures or, interictal continuum, things like this, that's going to warrant a little bit longer monitoring. So one study noted that 28% of those patients with electrographic seizures were detected after at least 24 hours of continuous monitoring, whereas most of them, about 94%, were detected within at least 48 hours of monitoring. So depending on the clinical situation, 24 hours may be sufficient, or you may opt for a little bit longer period of monitoring. In patients in a coma, 36% of patients required continuous EEG monitoring for greater than 24 hours to detect the first seizure. So there's definitely a difference in how you approach this type of monitoring based on what the patient's doing clinically and whether or not their level of awareness is fluctuating, or if you have any way to assess, right? It could be really hard to figure out what's going on in a patient that is completely obtunded, intubated, sedated, on pressors, whatever it is. And so that's where I think this data can be incredibly helpful in driving our treatment decisions.
Oh, wonderful point. And, we all know that not every place can have the continuous EEG monitoring, and those would be the moments that you might reach out to a facility that they do have the continuous EEG monitoring to transfer the patient for a higher level of care. So back to our case, the patient was having abnormal rhythmic movement and altered mentation on arrival. So we carefully monitored her for her airway protection while treating her with lorazepam. As Dr. Nankee mentioned, lorazepam, while we are getting the Keppra ready. And what we did was 2 milligrams of lorazepam twice, 5 minutes apart, and we started Keppra load, which the typical load for status epilepticus is 60 milligram per kilogram, max dose of 4,500 milligram. And as a side note, we did a started on nicotine drip because it's important to lower her blood pressure down to 140 to prevent any hematoma expansion. She was admitted to the ICU for close monitoring of seizure and ICH. She was already hooked up to the continuous EEG monitoring while everyone else are doing the medication. And, the process really has to start in the ED if it's possible to start hooking them up to continuous EEG. And we stopped the EEG when she was 24 hours seizure free and didn't have any epileptiform discharges. And, she gained her consciousness and we were able to monitor her through her clinical exam. And also about their ICH management, it's really important to not forget about that you got to repeat the head CT every 6 hours until you make sure that the hemorrhage is stable. So it's really important, honestly, to know that the patients are more likely to lose their airway from an untreated clinical status epilepticus than receiving a 4 milligram of Ativan to abort the status or abort the seizure. If a patient arrives and is clearly not protecting their airway, they will be intubated. But don't be afraid of using a generous amount of benzodiazepine to abort the status epilepticus, the generous and the recommended dose, while monitoring them closely. And sometimes you might have to go with a prophylactic intubation if it's needed, but it's important to stop the status. That's more helpful for the patient's outcome.
I think this is a really, really important point that was driven home during my medical training and residency. And then the other point that I would make is don't fear the Keppra, right? So 60 mg per
Exactly.
kg, I think is sometimes to a non-neurologist a little bit shocking to hear over the phone. And so, we're usually prescribing Keppra if we're just doing it in the outpatient setting, maybe 40 per kilo, depending on the situation, or, start low, up titrated as needed. But here, this is a different situation. This patient is in status. Our goal is to stop the status. And so you really just want to slug them, try and get the concentration of that drug high enough to treat the seizures. So don't fear the benzos, don't fear the Keppra. So along these lines, our patient came in clearly seizing, EEG evidence of such. What do we do about patients who have a large bleed but haven't demonstrated clinical or electrographic seizures? So the current guidelines actually do not recommend the use of prophylactic anti-seizure medication in patients with spontaneous ICH without any evidence of seizures. There was a meta-analysis. It included an RCT and then 7 other observational studies. They found that seizure prophylaxis in patients with ICH was not associated with preventing either early seizures, defined as less than 14 days from their hemorrhage, or long-term seizures. On the other end of the spectrum, right? So thinking prophylactically and then in the long term. So we also need to recognize that there are patients that may go on to develop seizures later. So there is a long-term seizure risk in these patients with ICH. So up to 10% of ICH survivors will go on to develop additional seizures later on. These are thought to result from neuronal organization and formation of epileptogenic foci from the prior hemorrhage site that then, as we know, turns into a scar and encephalomalacia, but still serves as a nidus potentially for future seizure activity. So there was a score developed called the CAVE score. This is a validated tool that can be used to estimate the risk of these late seizures after 7 days after ICH. And the score takes into account whether or not there's cortical involvement, the age of the patient, so younger age, larger ICH volume, and the presence of early seizures, as these features were associated with the development of late seizures in a retrospective analysis of 2 studies that included over 2,000 patients. So this is really helpful in terms of risk stratifying people for who we think is going to go on to develop late onset seizures, but also recognizing not everyone that comes through the ED with a hemorrhage on their skin needs Keppra.
Yeah, well, that was a great point, especially in the outpatient setting when you're thinking about like, who do I really need to keep on seizure medication forever or like for a longer period of time? That CAVE score would be very beneficial. So some takeaway points from this podcast would be, honestly, the importance of early seizure detection and treatment in ICH patient to avoid hematoma expansion and status epilepticus, and empowering ED providers and neurology providers to feel comfortable using the appropriate and recommended dose of benzodiazepine. As Dr. Nankee mentioned, it's okay to use the right amount of benzodiazepine and Keppra, the recommended dose of 60 milligram per kilogram for loading dose as a second line of treatment after benzodiazepine to abort the status epilepticus at a local ED. And then if they need some prophylactic intubation, that's fine. And then you can request a transfer to a facility that they do have a continuous EEG monitoring to make sure they are not in subclinical seizures. Thank you everyone for joining us.
Thanks so much for listening today. If you would like to find out more about the AHA Hemorrhagic Stroke Initiative, please visit www.heart.org/hemorrhagic stroke. See you next time.
The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.